Hello, my name is Guillermo Moreno-Sanz. I'm the Global Scientific Director of Khiron Life Sciences Corporation, which is a Canadian-Colombian company with headquarters in Bogota, Colombia. I have a PhD in neuropharmacology. My area of expertise is the pharmacology of the endocannabinoid system, which is the target for the active molecules present in cannabis, such as THC, tetrahydrocannabinol, or CBD, cannabidiol. My talk today is going to be about prescription patterns and clinical outcomes from a large cohort of chronic pain patients prescribed with cannabis-based formulations at Serenia Clinic in Bogota, Colombia. The content of this talk has been accepted for publication at Frontiers in Pain Research. With the title Sex-Dependent Prescriptions Pattern and Clinical Outcomes Associated with the Use of Two Oral Cannabis Formulations in the Multimodal Management of Chronic Pain Patients in Colombia. I'm going to describe the patient population on this clinic called Serenia Clinic, which is specialized in the treatment of different ailments, especially chronic pain, anxiety, insomnia, or depression, with medical cannabis formulations. As you may know, the treatment or the usage of medical cannabis was approved in Colombia in 2017 in the form of oral extracts. So the flower presentation is not permitted, and these formulations are commercialized under the form of magistral formulations. So they need to be prescribed for a particular patient and for a particular ailment. So what we did was, out of the patient population visiting and receiving treatment for at Serenia Clinic from the period of May 2020 to September 2020. We first select those patients that actually reported a PROMS questionnaire, a patient-reported outcome measure questionnaire, aimed at capturing the improvement of the primary symptom from the moment they started to take medical cannabis. Out of these patients, we selected those that indicated chronic pain as the main symptom for which, or the main indication for which they will be treated with medical cannabis. Out of those patients, we excluded those that had certain inconsistencies between the medical records available at the clinic and the questionnaire reported by the patient, for a final clinical cohort population, for a final cohort of 2,112 patients that were finally included in the study. Among these patients, we can see that we have a clear bias towards female. 76% of the population were actually female, and 23% of the population were indeed male. Regarding the age groups, we have 67% of these patients were younger than 65 years old, while 32.3% of them were older than 65 years old. The access of these patients to the clinic, remember that this is a specialized clinic, were mainly through four different routes. Most of them, over 75% of them, were derived to the clinic through their contributive insurance, their Social Security. 3.2% were subsidized by the state. 18.9% were particular, so they were self-referred or they were walking into the clinic, and only 0.1% of them were referred by their label or work insurance. Out of all these 2,112 patients, we have 61% of diagnosed according to ICD-10 criteria with unspecified pain. 26.5% were diagnosed with pains from the muscular skeletal system, so LGS in general. 8.8% were due to neurological disorders, and we have other patients that did not, follow or were diagnosed with any of these indications. So out of the cannabis-based medicinal products available to prescribers in Zerenia, as we were saying, this is one of the strengths of the study. Normally, typically observational studies mix and match a lot of different products, routes of administration, dosification regimes. So in this case, available to prescribers at Zerenia Clinic, we have 4 magistral formulations. One chemotype 1 or high THC containing 20 milligrams per ml and less than 1 milligram per ml of CBD. We have a chemotype 2, magistral formulation number 2. It's a balanced formulation coming from a particular variety. All of these oral extras were monovarietal, meaning that they were not mixed from different varieties, but they were extras from a single variety. The final specification of the product is 12 milligrams per ml of THC, 14 milligrams per ml of CBD. And finally, we have 2 chemotype 3 formulations. One of them contains 30 milligrams per ml of CBD with less than 0.2% THC, and the other one has 100 milligrams per ml CBD with less than 0.2% or 2 milligrams per ml THC, which is similar to the concentration and the composition of the approved medicine Epidiolex. Here you can see also the major terpenes in the flowers of these varieties, for which, as we were saying, these are monovarietal extracts from these 3 chemobars. And the presentation of the magistral formulation is a 30 ml glass bottle with a syringe for the easier application in milliliters of the corresponding dose. So out of these prescribed chemotypes, we can see that, off the bat, we have the first striking observation. We see that 2 of these formulations accumulate over 99% of the prescription. So basically, the chemotype 1 high THC formulation and the chemotype 3 with 100 milligrams per ml formulation were almost non-prescribed to any of these patients. Really residual prescription, less than 1% among the 2 of them, and most patients were prescribed either the balanced formulation, FM002, almost 40%, and then we see that the main prescription was the CBD 30 milligrams per ml formulation, FM003, which represented almost 60%. So we have this 40 to 60 distribution among the balanced formulation and the high CBD 30 milligrams per ml formulation. You can see to the right the daily intake. Again, with such a big cohort, we were able to divide this cohort in groups by duration of treatment. So we divided these participants in those that were taking medicinal cannabis for less than 4 weeks, those that were taking between 4 and 12 weeks, so short time, mid time 13 to 26 weeks, and long time for over 26. As we can see that the typical dosification of medical cannabis is performed by titration, slow titration of the doses until the patient achieves symptomatic control of their ailment. So as you can see, expressed in milliliters, the volumes of these products that patients were taking depending on how long they have been taking medication for. As you can see, there is not a plateau of the doses that one could expect after reaching the optimal dosing. However, we see a steady increase, and then after 12 to 26 weeks, we have a much less steep increase in dosing, meaning that we are slowly reaching that plateau, and that actually patients do not need to further increase their dosification. Then another interesting observation that we see of the bud, this is the distribution between sexes, between female and males of the prescription of FM002, remember the balanced formulation, and FM003, the formulation with 30 milligrams of CBD, less than 0.2% THC. So we can see that overall, males were preferentially prescribed with the balanced formulation, less than 40%, less than 50% were actually prescribed with the CBD 30 milligrams per ml formulation, FM003, while in the case of females, more than 50% were prescribed with the CBD only formulation. And then we can see an interesting trend as we evaluate or analyze the period and the strength of the treatment. And you can see that while females keep the prescription over 50% at all times for the CBD formulation, you can see that males start with over 50% of prescription on the CBD 30 milligrams per ml. And then after 12 weeks, it's almost 50%. And beyond 12 and 26 weeks, we see a decrease of the ratio between those prescribed with the balanced formulation and those prescribed with CBD. There is two likely explanations to this. What we see is that there is a higher proportion of males switching chemotypes from their initial CBD 30% to a balanced formulation that might be more effective to these patients. And at the same time, we see a higher rate of withdrawal from treatment in those males treated with just CBD, owing maybe also to the limited efficacy of this formulation in this type of patients. We discuss in the paper that although this seems to be striking because the clinical evidence to support the use of CBD-only formulations on chronic pain patients is very limited, and we know that THC is the cannabinoid that is going to engage with CB1 receptors, and therefore being able through several mechanisms to palliate this chronic pain in this type of patients. We see that, especially in women, the case is that patients continue to report benefit from low doses, and I'm saying low in comparison with the clinical effective doses of CBD that we have from the Epidiolex clinical trials, still continue to report a benefit in their chronic pain. This might be also associated, others such as Stacy Gruber and other authors have also found and published similar observations in which CBD formulations might be affecting mood rather than the pain perception, but this at the same time contributes to an overall improvement of the health of these patients that might be related to this report of a benefit in their chronic pain condition. So those patients reporting a benefit are the absolute majority. As you can see, 9 out of 10 patients reported some degree of improvement, with less than 10% of patients reporting no improvement whatsoever. And then you can see also the degree of improvement in the graph to your right. As you can see, there's a Gaussian distribution centered on the 70% of improvement. So those are on the y-axis. You see the percentage of patients, and on the x-axis you see the percentage of improvement that these patients are reporting. So again, for clarity of interpretation, we represented this as 4 degrees of improvement residual for those responding 0 or 10% improvement, slight improvement both for those responding 20, 30, or 40% of improvement, moderate improvement for those reporting 50, 60, or 70% improvement, and robust improvement for those reporting 80, 90, or 100% improvement on their pain, on their chronic pain. As you can see, moderate and robust are related to a reported benefit higher than 50%. And here we have the degree of improvement by chemotype and by age group. So just talking about chemotype FM002, which is the balanced chemotype, or FM003, which is the CBD predominant chemotype, we see very similar responses in terms of the degree of improvement. And then dividing by young adults under 65 or elderly over 65, we couldn't find any significant differences. If any, you might see that or seems like medical cannabis works, or these elderly patients are reporting slightly less benefits. We can see that there is a little more increase on this residual plus slight improvement, both for both chemotypes. But again, these differences are not statistically significant. When we look at the degree of improvement by sex, chemotype, and treatment duration, we can see a clear trend on those patients that are treated for under 4 weeks. There is a much higher report of residual and slight improvement, and after the treatment or the dose, the ideal dose has been reached, the patient has get used to the side effects of the treatment. Their patients are starting to report a more stronger, more robust benefit. You can see the robust fraction on the dark side of the column on the top. But when we add robust plus moderate, we see how there's this trend towards a much better improvement as the treatment goes by. So basically, after 4 to 12 weeks, we're reaching maximum levels of benefit at treating this chronic pain at these patients. Again, besides the efficacy of the treatment at benefiting this control of chronic pain, we also ask patients to report a series of side effects that could be associated to the treatment. So occurrence of adverse side effects, this is the total amount of patients. This is the 2,112 cohort. 70%, almost, more than 70%, 71.7% of patients describe no side effects at all. The most frequent side effects was somnolence. We'll see a breakdown now by sex and chemotype as well, followed by dizziness with 8%, dry mouth at 4.26%, and other minor side effects. We're going to see a table right now. So maybe you cannot see in detail. Please, I will refer you to the open access publication that captures all and reports all this data. As you can see, or as we'll be describing, the major side effects are going to be somnolence, dizziness, dry mouth, and then we have others such as headache or anxiety, but already appear as very, very minor, rare cases. Interestingly, obviously we have more CNS-related side effects with the chemotype 002, with the chemotype, with the balanced chemotype, the formulation that contains THC. However, we still see, side effects such as somnolence or dizziness related to very low doses of CBD. We're going to see a breakdown of that immediately. As you can see in here, we have up to 30% of patients, especially females, reporting somnolence associated with the formulation that contains THC. Even if it is a balanced formulation, we know that CBD might counteract some of the side effects, more overt neurological side effects caused by THC. But you can see that the female population, both at under 4 weeks and up to 12 weeks, describes a huge incidence of, compared to the rest of side effects, of course, incidence of somnolence, specifically females. We don't see that on males, but at the same time, we see how the incidence of somnolence is reduced after these 12 weeks of treatment. On the other side, we see that the rest of the side effects, there is not a clear marked difference between males and females, and also between the THC containing formula and the CBD only formulation. You can see that obviously they're reduced within time. So, I mean, as others have described, these type of side effects are mild and do not interfere with regular day life, and they're also transient, and they tend to reduce as the patient optimizes the dose and gets used to these side effects. So in conclusion, we can say that first, both males and females reported more significant benefits after the initial 4 weeks once an optimal dosing regime was reached, and that this period was also associated with the highest incidence of adverse side effects, remember, in particular, somnolence for the female participants. It is therefore extremely important for both patients and prescribing physicians to persist with therapy through this initial dosing adjustment phase. As we were saying, and we discussed in the paper, this seems to be a trend by several clinicians in many different jurisdictions, such as Canada, Israel, the UK, in which physicians tend to start patients with CBD-only formulations just because it's safer from a side effect point of view. However, as we have seen, particularly in male population, this might also be related with withdrawal from treatment due to the lack of effect of these formulations, especially for chronic pain. So establishing treatment goals during the initial consultation can be very helpful to provide a structure to this process of going through the first 4 weeks of treatment to achieve the most benefit from medical cannabis treatment. Secondly, most observational and experimental studies investigating the efficacy of cannabis-based medicinal products for pain management are of relatively short duration, generally under 4 weeks. Our results indicate that the perceived effectiveness reported by patients was maintained on the short, 4 to 12 weeks, intermediate, 12 to 26 weeks, and long-term, over 26-week duration of treatment, which is well aligned with the results from randomized clinical trials using nabiximols, which, as you know, it's an ethanolic extract for sublingual administration that contains equivalent concentrations of THC and CBD. So, as we were saying, randomized clinical trials using nabiximols in MS patients, in multiple sclerosis patients, show sustained improvements in pain and other symptoms for more than 12 weeks without developing tolerance. Finally, as I will say, takeaway results from this research, we see that 9 out of 10 participants reported some degree of improvement in the control of their chronic pain symptoms. 7 out of 10 participants reported an improvement equal or larger than 50% since starting the treatment with cannabis-based medicinal products. And 7 out of 10 participants did not report any side effect. Treatment with medicinal cannabis was generally well tolerated, no serious adverse events occurring, and as suspected, the THC-containing formulation was accompanied by a significantly higher prevalence of central nervous system-related side effects, such as somnolence, especially in the female cohort, and dizziness, which were more prominent in the first 4 weeks of treatment, as we were saying. Also, these side effects appear to be transient, reducing their impact on medication as the treatment goes on. So this was my time. Thank you very much for attending this seminar. I remain at your disposal for any further questions that you might have. You can reach me on my email, gmoreno, Gmoreno, at Khiron, Khiron.ca. Thank you very much to LabRoots for giving us this opportunity to present our results. And again, you can look up for the publication of these results in the journal Frontiers in Pain Research. Thank you very much for your attention.